Everyone, I hope everyone is doing fine. Let me introduce myself. I am Dr. Sumbal Ijaz, your MRCOG-1 mentor here with Instutors. So we have arranged this session. Basically, in today's session, we will cover how to quickly revise important topics from all the subjects which are included in your RCOG curriculum. So that we can make most of this last month and finish, and we will finish today's session with a short mock exam. So I can see that we have many January candidates with us today. So I will try my best to address both January and July candidates. So let's start. So I understand for the July candidates, we have very short period of time left for the exam. We roughly have 1 month. So what you can do in the last month, first of all, you have two things to cover. One is your theory and other is your SPS practice. So as far as your theory is concerned, I never recommend my students to go and stick with the theory books for a very long period of time, especially during this last month. I wouldn't recommend anyone to go and revise Oxford or Essential Revision Guide or any notes you are following at the moment. So what you can do just to quickly revise your basic information or basic knowledge, just try to read the high yield points. So the first point, which is organize your notes. This is basically, this is something which you usually do when you start preparing for your exam. So this tip is mainly for the January candidates. So since you have started your preparation now, so what you can do in order to save your time in the last month, try to highlight the important points and the high yield points. For instance, if you are studying anatomy and you have found that the particular nerve innervation is important, so just highlight that point, so that what happens when in the last month you are revising your theory, you just turn around the pages, read those high yield points and move on. So that would quickly help to quickly revise all the information. And if the July candidates, they have already done that, then that's very well done. So it would, because it would save a lot of your time. So now in this last month, your job is to just quickly revise the high yield points, either from an Oxford Essential Revision Guide, from the notes or any PDF you are following at the moment. Then you can also utilize active learning techniques. So what are active learning techniques? This is something which includes the flashcard method, the quiz. You may solve many quizzes as much as possible. And some students, I have noticed that they sometimes they make some sticky notes on their books or in their bedroom or in their any notice board if they have in their bedroom. So that's a good thing. This is something which we called as active learning techniques. So if you don't have your flashcards, if you don't have your sticky notes, don't worry about that, because we Instutors, we are already working on that, and we have made some flashcards for you, and as well as we have made some sticky notes for you. Then the quizzes. Regularly test yourself with practice question and past papers. And trust me, this is the key to pass this exam. The more you practice SBS, the more are the chances that you will pass in the first go. And this is something I kept on repeating since the day one. I remember when I did my first session for the July candidates on the ABC of MRCOG-1. This line I have added in that presentation as well, that the more you revise the SPS, the more are the chances you will pass this exam. So this is a demo. Like, I understand anatomy is really, really volatile. And even if I remember my time, in the last 2 weeks, I forget everything from the anatomy. So what I did, I opened the Oxford Revision notes and I try studying anatomy again and again. I was watching videos on the YouTube, and in that way, I wasted a lot of time because I had no guidance like how I can tackle the anatomy at the last 2 weeks or 3 weeks or so. So what you can do here, I have added some points from my experience. So what you can do, yes, I understand again, anatomy is volatile, so you can spend a bit more time on it. So when, for example, if you are, we already know we have anatomy of abdomen, anatomy of pelvis, and anatomy of perineum in the RCOG curriculum. So for instance, if you have started studying pelvic anatomy, so try to focus on the high yield points. These are the points from which the mostly questions comes from. For instance, if you have started from pelvic bone, joints and ligaments, and now we know that what are the important joints and what are the SBS they are coming from this topic. So please tell me in the chat box, what are the two important joints in the female pelvis? My question is, what are the important, name any joints which are important in the female pelvis? Yes. Now tell me what type of sacroiliac joint is. Yes. And what type of pubic symphysis joint? Yes, perfect. So this is how you can tackle your theory. For instance, you have a big page of female pelvic joints. So you know what type of information you need to extract from that topic. So this is why I asked this question. Same goes with all the topics. You know, when you are studying pelvic floor muscles, now you know what, please tell me, what muscles make the pelvic floor. Name those muscles which participate in the formation of pelvic floor. Yes, perfect. Okay, so now you get an idea. Okay, what is fascia? I think this question covers your perineal fascia, your perineal membrane, and the questions which are related to that. Okay, then we know that we have messing over head since the last 3 months that what is the blood supply of which structure, which organ, what is the lymphatic drainage of which structure and which organ. So you have to cover that. So the important blood supply when it comes to the pelvis, we know pudendal artery, internal iliac artery, external iliac artery, lymphatic drainage. We know that what are the particular groups of lymph nodes which are involved in the pelvic drainage. Then innervation, we know perineal nerve, pudendal nerve. We frequently practice those SPAs. So again, what I'm trying to say here is that whenever you are covering these high yield points, you have crystal clear understanding that what kind of information you need to extract from the theory so that you won't waste your time. I won't recommend you at this very time that you spend 5 to 6 hours on the theory books. So be quick, be smart, and study smartly so that you will save your time. For example, you are starting your revision from a day after tomorrow, and you are going to start from anatomy. So try to cover these all high yield points maximum into 3 hours, and save your rest of the time for the SPA practice. So this is how you can cover a bit of your theory and also your SPAs as well. Similarly, the other high yield topics or the points are anatomy of female reproductive system, external and internal. It is a summary. Mainly, it covers the questions which comes from the vulva or the external genitalia and as well as internal genitalia, like the innervation of the cervix, lymphatic drainage of the cervix, and same the blood supply of the uterus or the ovary, etc. Anatomy of the male reproductive system, embryological and development of the reproductive system. Then perineum and external genitalia, we are fully aware of that, what kind of question we have already practiced so many times, like what type of information we need to extract from the theory of perineum and external genitalia. Then abdominal wall, yes, layers of abdominal wall, they are important. Anatomy of inguinal canal and its content, it is very, very high yield topic, so don't miss that. Hernias, a bit about what is inguinal hernia and what is femoral hernia and femoral canal, a bit about these topics. Then neuroanatomy in RCOG curriculum mainly covers the nerve innervation, both autonomic or somatic or motor innervation of different vistas in the abdominal or perineal or pelvic cavity. Pudendal nerve is very important. Pudendal nerve and its branches, sensory and motor innervation of pelvic floor and perineum. Then when it comes to embryology, okay, these points, it doesn't mean that you only covered these topics from embryology. I have just make a systematic presentation. So like if you are covering abdomen, pelvis, and perineum from the anatomy. So meanwhile, you can cover the development of sexual reproductive organs as well from the embryology. However, they are very high yield topics. You cannot afford to miss these topics. The topics from embryology are development of genital and urinary systems, congenital anomalies of reproductive tract, placental development and structures, and also the anomalies of placenta. So these are very high yield topics from embryology. Then histology, okay, mainly the histology covers the types of epithelium of different structures. So this one is easy. Spermatogenesis, oogenesis, clinical correlations. Understand the common clinical conditions and their anatomical basis and application of anatomical knowledge to clinical scenarios in OBS and gynae. So they covers many of your anatomy SPAs. This domain covers many SPAs, like we have different scenarios in which they give a clinical scenario that a surgeon is performing a particular surgery. So what type of structure is at risk of injury? Maybe artery, nerve, or anything. They may ask you relation of ureter with the blood supply and everything. So these are your clinical correlations of anatomy. Is everyone following me so far? Are you clear now, like how if you are trying to revise your theory at such a short period of time, like how you're going to cover that? This is a brief summary. And this is how you can cover all of your high yield topics of anatomy. Okay, so here we have made some sticky notes for you. Yes, Dr. M, you may ask. Okay, Dr. Iram, you may write your query completely, then I will address that. Okay, so we have made sticky notes for you. These are some important percentage because we are observing so far that most of you are confusing the percentages, and you find this knowledge very difficult and this area very difficult, like how we can remember percentages, how we can accurately remember those. So we did an attempt to make sticky notes out of that knowledge. So here are some high yield points. We know that there are two genes mutation which are involved in the development of breast cancer and ovarian cancer, and these two genes are BRCA1 gene and BRCA2 gene. However, the risk for the development of those with those cancer varies. So lifetime risk for developing breast cancer for a patient or a person who have BRCA1 mutation is 60%, and for ovarian cancer, it's 40%. Similarly, for BRCA2, the lifetime breast cancer risk development is 45%, whereas for ovarian cancer, it's 15%. So what you can do, it's all about memorizing this such type of information. So you just save those sticky notes, and later on, just if you find any time, if you have 1 minute to quickly revise this thing, just have a look, and meanwhile you will remember these percentages. So again, revision is the key. So some of the questions come from the blood cell lifespans. So it is a list. Here is a list for all the blood cells. Like our red blood cells have a lifespan of 120 days. Platelets have half lifespan of 5 to 9 days. Sometimes they roughly give you the value of 10. If you find an option of 10 rather than 5 to 9, you may go and choose the 10 in order to select the lifespan of platelets. For white blood cells, it is 2 to 5 days. For neutrophils, it is up to 5 days. Basophils, 2 to 3 days. Eosinophils, 2 to 5 days. Monocytes, 1 to 5 days. And lymphocytes, they are variable. So again, this is for your quick revision. Here is another sticky note from the genetics. In order for the screening, we use the triple test technique, quadruple test, and combined test. So in triple test, we offer alpha fetoprotein, HCG levels, and UE3 levels. In quadruple test, we have an additional inhibin A factor, inhibin A test. Then in combined test, we do pregnancy associated protein A and HCG and ultrasound. So this is an additional thing. Then we have another sticky note from genetics, which is detection of macromolecules. So in order to detect protein, we go with the Western blotting technique. In order to detect RNA, we go with the Northern blotting. And in order to detect DNA, we go with the Southern blotting technique. So these are your simple SPAs. Then this sticky note is from biochemistry, I guess. Yes, they are vitamins and their associated abnormalities. Like in the deficiency of thiamine, what type of condition a person might develop is the beriberi. For vitamin B12 is pernicious anemia. Vitamin B3 deficiency leads to pellagra. Folate leads to macrocytic anemia. Ascorbic acid, which is our vitamin C. If there is no vitamin C, the person might have scurvy. Then folate deficiency may lead to tropical sprue, which is a malabsorption syndrome. Okay, and this sticky note is especially okay, Dr. Yam. Definitely, I will address once I finish these flashcards. Okay, so this flashcard is from maternal CVS adaptation during pregnancy. So what type of changes we observe during pregnancy in terms of CVS system? So systolic blood pressure. Okay, let me give you a background. What happens during pregnancy? We have two main reproductive hormones. One is estrogen and one is progesterone. And these are the two hormones which are responsible for the maternal adaptation during pregnancy. So when we talk about the CVS adaptation, since the baby is growing, so the growing fetus demands increases in terms of blood, plasma fluid, oxygen, food, nutrients, and everything. So in order to meet the demand of the growing fetus, the body has to adjust itself. So what happens? The estrogen, it affects on the kidneys and increase the renal absorption along with the sodium. And as a result of that, the preload on the heart would increases, the plasma fluid increases, and once the preload is increases, then definitely the afterload would also increases. There's increase in the heart rate, and meanwhile the progesterone decreases the peripheral resistance, which leads to the drop in the blood pressure. So this is how the body is adjusting itself. So the systolic blood pressure drops is by 5%, diastolic 10%. RBCs increases 18%, heart rate increases 20%, stroke volume increases 30%. Okay, stroke volume is cardiac output into heart rate. If cardiac output is increasing, heart rate is increasing, then definitely stroke volume would increase. Cardiac output increases 40%, plasma increases 50%. Here is another high yield point. We can see that plasma is increasing 50%, whereas RBC is increasing 18%. However, apart from that increase, still the patient may have anemia, which is hemodilutional anemia, which is totally physiological. So if you find in a pregnant lady hemodilutional anemia, please don't go for the treatment because that's totally normal, that's physiological. Yes, hemodilutional. Yes, that's perfect. Then we have percentages of different chromosomal abnormalities. Okay, Patau syndrome, the incidence of Patau syndrome is 1 into 15,000. Edwards is 1 into 5,000. Down is 1 into 1,500. Turner 1 into 5,000 females. And Klinefelter's 1 into 1,000. So you have to remember that anyway. So this is your task to memorize this. Similarly, here is a maternal age risk of Down syndrome according to the age of the mother. So by the age of 30, there is risk of 1 into 2,500 with increasing age. The risk is 1 into 800. By the age of 40, it is 1 into 100. 45, by the age of 45, it is 1 into 1:30. And 50, by the age of 50, it is 1 into 11. So you have to memorize this on your own. Okay, so now we imagine you are starting your revision, you are focusing on the high yield points, and meanwhile you have some of the flashcards and you have some sticky notes of the high yield information. Now you have enough information now, but you have to practice, you have to assess yourself, and you have to evaluate yourself to see your weak points and to work on those in this last month. So for that, I would recommend you to go and solve the mock exams. It's up to you how you will manage that. However, we have mock exams, subject-wise mock exams available on our website. If you have that chance, you can grab this opportunity and go on our website and solve those mock exams. So this is one thing you can do, or you may go and have some prints of any, you may solve any books of SVS, it's all up to you. But the main thing is you have to practice again and again before the exam. Okay, again, this is something I have already told you, like for the revision of your basic knowledge, you may use multiple resources like textbooks, including your Oxford revision note, essential revision guide, or you can go with the online courses and lectures. You may solve the question banks, utilize MRCG Part 1 question banks and mocks exam. For those who have access to our website, they can go and solve the mocks and they can watch the videos or read the PDF. And who do not have the access, they can go and choose any of the books and practice there. And I'm sure by now you are fully aware of these books. So it's all up to you. Okay, now we know what is the strategy we need to follow, what type of information we need to focus on, and how we can evaluate ourselves. Now the main thing is that how we can manage our timetable. So here are some tips. Create a revision timetable that allocates time for each topic, ensuring that all areas are covered well before the exam. Then take the incorporate regular breaks to avoid burnout. This is something I need to follow, because whenever I start to preparing for the exam or started studying for anything, I just straight go and study for 7 to 8 hours without any break. So I need to follow this. So take break, in order to avoid burnouts, use techniques like Pomodoro method, that is 25 minutes study and 5 minutes break. And I need to follow this again. So the next step, active recall and spaced repetition. Active recall, test yourself on the material rather than passively reading it. That means if you are just reading the information from any theory or anywhere, that is not enough unless you solve the SPS and challenge yourself. Then spaced repetition, you may follow this technique, review material at increasing intervals. For example, one day you have studied one subject, then after 1 week, revise that again. And after that, you may revise that after 1 month. So this is a tip for the January candidates, because our July candidates do not have enough time. One thing which is very important is the group study or the group discussions. You may join different platforms, different groups on the WhatsApp, on the Telegram group, or you may join our Telegram group for the practice of SPAs. You may find a study partner on those platforms, and you may set your timetable and practice every day with your study partner, because in that way, the more you discuss, the more information you will retain, and more of your concepts would be clear in that way. So have a study partner. Yes, now imagine you again, you have revised your theory successfully, you have your study partner, you have a Telegram group, you have some supervision, and you are solving the mock exams, and now you know your percentage, you know your weak areas. So your task especially after solving the mock exams, to identify your weak areas and try to focus on those more. So regularly review your progress and focus on your weak areas. Then if you don't understand like how you tackle those weak areas, you might take any professional guidance. So you may go with the courses and tutors. Consider enrolling in the professional revision courses or hiring a tutor if you need structured guidance. So it's all up to you. Mentorship, seeking advice from colleagues or mentors who have successfully passed the MRCOG Part 1 exam would be really, really helpful, because I believe you may find all the information on the Google, you may find all the information on the YouTube, you may have multiple platforms from there you can gather maximum information. But one thing which is not available on any of the platform is the experienced advice. So here is something, you need a mentor, and that mentor could be your friend, your senior, your colleague, or any professional guidance you might be taking. So mentorship is important because this is something which is not available in the books as well. This is solely something which is coming out of experience. So yeah, have a good mentor. Then how to revise your notes again. There are some exam techniques like time management. Like when you are solving the exam, on the exam day, you have 100 SPAs and 150 minutes. That means you have 1 minute for each SPA. So this is a reflex you have to build while you are practicing your recalls. So try to solve your SPA in less than 1 minute. So that in the exam you have, if you find any difficult SPA, so you have enough time to solve that. So build your reflexes, as work on your time management. That's important. One thing, again, read question carefully. Start by thoroughly reading each question to understand what is being asked. This is very important. And I understand we all are at some point, we are all at learning stage. We all are students at some point, and we all do such kind of mistakes. Even I do such mistakes. So this is for me, and this is for you as well. Read questions carefully and start by thoroughly reading each question to understand what is being asked. And also read the other options carefully. Identify and solve easy questions first. Okay, what I did in my exam, there are some options. For example, you have started your paper 1. When you solved all of your 100 SPAs, there is an option of red flag. Like if you find an SBA very difficult and you are not sure about the answer and you don't want to risk to answer that question at that very moment, you can simply red flag that question. So after 100 questions, you will get a list in which those red flag questions are on one side, unattempted questions are on one side, and attempted questions are on one side. So that will give you a clear, crystal clear idea like where your exam performance is standing at the moment. So your solved questions are those questions on which you are 100% sure. So try to go and solve those questions in the first go on which you are 100% sure, because at the end that would help to boost your confidence. Then go with the unattempted questions and the red flag questions, review them again and again. Yes, Dr. Nareen, definitely we can review our answers, we can change our answers.
Huh? Okay.
Dr. Nancy, could you please turn off your mic? Okay, so manage your time efficiently, allocate time to each question 1 minute and stick to it. And I would recommend try to solve SPAs in 45 seconds. Don't go with the 1 minute. Avoid spending too much time on any single question. Okay, this is a tip for the exam day. Try to solve those questions on which you are 100% sure, and honestly that would take 30 seconds maximum if you know the answer, and if you are having some easy questions. And those saved 30 seconds you can utilize for reviewing your red flag questions and your unattempted questions. So this is how you can manage your time. Mark difficult questions for review. This is that point in which you are going to red flag your confused questions. If you are not sure about the answer, or for instance, you are confused between B and C, and you want to review that later on, just simply red flag that question. And after solving your 100 SBAs, then come back and review that question. You can simply red flag any question, even the attempted question, even the unattempted question. That's all up to you. All those questions have a red flag mark on the top of that. You can easily mark that. Okay, then yes, stay calm and focused. Maintaining a calm environment will help you think more clearly and reduce anxiety. Practice deep breathing or a quick mindfulness exercise if you feel stressed. Okay, so if anyone have any question regarding like how you can make a quick revision plan, how what type of tips you need in order to solve the exam, you may ask me. Otherwise, I will move on to your mock test. If you are ready for the mock exam, then please do let me know. And don't be afraid, it's a short mock exam. Dr. Bhavna, if you have enough time, then utilize all of your time, because the time is, you just have 1 month. So try to make maximum out of this time. Yes, Dr. Fatma, we can change the answer. Okay, what I did, I solved some of the questions in one go in which I was sure enough. And at the end, I saved the biostats question. And during the last 30 to 45 minutes, I have enough time for the biostats. So I saved 45 minutes for 10 biostats question. And yes, they will provide you with the paper and the pen so that you can do your calculations there. Let me confirm this from the management that are we going to share the sticky points or the flashcards to this workshop? Because I'm not sure about that. Okay, let's start our mock exam. So one thing, don't change your answers. If you are answering, for instance, A, I will lock that answer. And the second thing, try to answer the question in 45 seconds. Dr. Hassan, there is a percentile system and the average would vary in each exam. Sometimes it reaches up to 73% as well. Okay, your first question. Patient with heavy menstrual bleeding, identify the picture. Okay. Okay, I think I've got enough answers. So let me ask a question from, let me see your answers. Dr. Sara, why did you go with the option C? A, polyp is the right answer. It is uterine polyp, also known as endometrial polyp, form as a result of cells in the lining of the uterus overgrowing. So A is the right answer here. Okay. Okay, what I'm gonna do, I will set a timer so that you know the time's up. And once the timer beeps, I will move on to the answer slide. Let me set my timer first. I'm setting the timer on 45 seconds. And after 45 seconds, I will move on to the answer slide. Give me a second. Okay, your time starts now. Which of the following is most indicative of this placenta anomaly? Okay, your time's up. Yes, C is the right answer. Filamentous placenta is an abnormal cord insertion in which the umbilical vessels diverge as they traverse between amnion and chorion before reaching the placenta. It is characterized by membranous umbilical vessels at the placental insertion site. If you can see here, the remainder of the cord is usually normal. So let me give you a brief about rest of the placental types, because this is a high yield topic. So if so for velamentous placenta, we have already discussed, it is happens when the umbilical blood vessels abnormally travel through the amniochorionic membrane before reaching the placenta proper. Then we have another modification, which is bilobed placenta. So if we found here, okay, there is no picture of bilobed. Okay, this is a bilobed placenta, and it is obvious that it has two lobes. It is also known as placenta duplex. This is a case where the placenta is composed of two roughly equal sized lobes. Okay, let me zoom in. Okay. I hope now you can see the pictures clearly. Okay. Is it clear now? Okay, maybe your network is not working fine. Okay, later on you can watch the video, and you can zoom in. Okay. Then we have another modification, which is succinate. I don't know how to pronounce that. My pronunciation is not that very good. So succinate placenta, whatever you pronounce that. In these cases, a lobe of placenta forms separately from a main body that is linked via the umbilical cord to the fetus. This is here. You can see this variation here. It is another type of it is a separate placenta, which is totally separate from the main placenta. However, it is linked with the umbilical cord. As you can see here, it do have a link with the umbilical cord, but it is a separate mass of placenta. Circumvallate placenta, this is when the membrane of the placenta tucks back around its edges to form a ring-like annular shape. So here you can see it has an annular shape, a ring around this placenta, and it is very easy to diagnose this. If you find an annular ring around the placenta, that is, it is circumvallate. And similarly, if you find a picture in which a placenta have two lobes, and go and choose a bilobed placenta or the placenta duplex. Then we have circumvallate placenta. Okay, we are done with that. We have circummarginate placenta. This is much less problematic variant of the above, in which membranes do not curl back. So here you can see, yes, there is the outer rim around the placenta, but that is not fully covering the placenta. So this is circummarginate. That means only margins are abnormal. Then Betadol placenta, sometimes called marginal cord placenta. Placental insertion. This is when the umbilical cord runs through the margin of the placenta rather than the center. So here you can see how the umbilical cord insertion is around the margins rather than the center point. So this is how you can diagnose or do your spot diagnosis on the basis of the shapes of placenta. And this is a high yield topic. So that's why I have added this extra slide in this mock exam. So again, this is your velamentous, and these are your rest of the placental anomalies. Is everyone clear about this topic? Okay, good. Let me set my timer again. Okay, your time starts now. Identify the following structure. Okay, your time's up. Yes, A is the right answer. Let me break down this picture because this is very important and high yield. And many questions come from the oocyte in the exam, as well as from the oogenesis and spermatogenesis. So this is a high yield topic. So in the center, okay, tell me, is it primary oocyte, secondary oocyte, or a tertiary oocyte? Okay, I think I have a question. Yes. Yes, this is secondary oocyte. Yes, absolutely. That's perfect. Okay, how you can identify tertiary oocyte? Here is the first polar body. Dr. Iram. Yes, Dr. Lirip, what type of cavity, what we call that? Yes, antrum. Well done, Dr. Kiran. Yes, antrum is the right answer. There is a big cavity in the tertiary follicle, and sometimes we call that as antral follicle as well. Yes, perfect. Let's move on to the next question. Your time starts now. Sorry, my slide is stuck. Let me check. Okay. Okay, start. Okay, your time's up. Dr. Ankita, why did you go with the options C? A is the right answer. Well done, everyone. Okay, yesterday I was going through from the WhatsApp group and I have found a question that some of a student was finding difficulty in the interpretation of spirometry. So that's why I have added this slide, is this question, so that I can teach you how we can interpret spirometry. This is a very easy topic. Okay, in our lungs, we have different volumes, and when we sum up those volumes, we get capacities. So in order to interpret spirometry, we have two types of categories to choose. One is our lung volumes, and the other is our lung capacities. So let's have a look on lung volumes. So majorly we have divided our lung respiration into 4 volumes. So let's have a look. This is the spirometry. For instance, as in this question, you will find this spirometry and they ask you to diagnose a particular region. So this is how we can break down that spirometry. Let's start from the basic, which is our tidal volume. Why I'm saying that it is our basic volume, that the breathing we are doing at the moment is we are breathing at our tidal volume. So what does that mean? It is the volume of the air we inspired or expired with each normal breathing. Is everyone following me? Are you clear what is tidal volume? It is our normal breathing, the breathing you are doing at the moment, and the breathing I am doing at this very moment is our tidal volume. So this is your tidal volume. So if you find a spirometry in your exam and they have put a question mark here, as you can see, it is a normal breathing pattern in a normal rate in a normal pattern. So this is your normal breathing, this is your tidal volume. If you find a question mark here, that means go and choose the tidal volume. Then the next is your inspiratory reserve volume. Reserve means this is some extra space we keep. This is something like we have a house, we have 2-bedroom house and 1 room we reserve for the guest. And when do the guest, whenever the guest comes, they utilize that reserved room. Similarly, in our lungs, we have some reserve volumes. The inspiratory reserve volume is the reserve volume for the extra air, and extra air comes through the inspiration. So that's why we call this as inspiratory reserve volume. So here we are breathing at the normal tidal volume. So the area above that is our inspiratory reserve volume. This is the guest room for the extra air. Is everyone clear about inspiratory reserve volume? Okay, because this is the 3rd time I'm teaching how to interpret spirometry, and this is the last time I'm teaching to the July candidates. Okay, so listen carefully and understand spirometry now. Okay, so now we have tidal volume. I'm gonna repeat again and again so that you will remember. Okay, so tidal volume, what was the tidal volume? The normal breathing you and me are doing at the moment is our tidal volume. Then we have some reserved volume for the inspiration or the new air, which is our inspiratory reserve volume. So if in the exam you find a question mark on above the tidal volume, that means go with the inspiratory reserve volume. Then similarly, if we have a reserve space for extra air, we have some extra reserve area for the air which we want to expel extraordinary. So this is our expiratory reserve volume. This is the air, this is the volume which utilize when we exhale at our maximum. So in physiology, we call expiratory reserve volume is the volume that can be expired after expiration of a tidal volume. So the area beneath the tidal volume is your expiratory reserve volume. So this is our 3rd volume. Then we are left with residues. Always the thing which is left at the end or the bottom is our residual thing. Similarly, in the lungs, after our tidal volume, after our guest inspiratory reserve volume, and after expiring at our maximum by utilizing expiratory reserve volume, we are left with the residual volume, which is, since the residual thing is always at the bottom, similarly, residual volume is at the bottom. And this is the volume we will never ever during our life we utilize this air. This is the air which never ever participate in the gaseous exchange. After that, death maybe, if someone during autopsy pushes the lungs, so maybe that air comes out. Otherwise, in a living human being, this air which is present in the residual volume never ever comes out of the lungs. Now, please tell me if you have any question regarding lung volumes, please ask me so that I can move on to the capacities. Okay. So again, which one? Okay, Dr. Ankita, she goes with the inspiratory reserve volume. She answered C. Maybe she confused with this word, maybe. But this is our residual volume. And this is our tidal volume. This is our inspiratory reserve volume, and this is our expiratory reserve volume, and this is again our residual volume. Now let's move on to the lung capacities. So similarly, we have 4 lung volumes, we have 4 lung capacities. So basically the capacities are the sum of volumes. Let's see the combinations. First, we have inspiratory capacity. So inspiratory capacity is the sum of tidal volume and inspiratory reserve volume. So here we have our tidal volume, and when we add up this inspiratory reserve volume, we call this as inspiratory capacity. That means this is something, this is the maximum amount of oxygen we can inhale or we can inspire. So from where this inspiration covers, it is covering the inspiratory reserve volume, and also it is involved in the tidal volume, because in tidal volume, yes, we are inspiring and we are utilizing some oxygen, right? So inspiratory capacity involves both inspiratory reserve volume and tidal volume. Then functional residual capacity. So residual means we have to go to the bottom. So in bottom, we have residual volume, we know that. In addition to that, we added expiratory reserve volume. If we combine residual volume with the expiratory reserve volume together, it is known as functional residual capacity. This is our functional residual capacity involving residual volume as well as expiratory reserve volume. Then we have vital capacity. It is a sum of tidal volume, inspiratory reserve volume, and expiratory reserve volume. Or you can say vital capacity is the active unit of the lungs. It is the active capacity of the lung. That means it is that part of the lungs which is fully participating by any means in the gaseous exchange. So now we know that, yes, number one, tidal volume, yes, it is involving in the gaseous exchange. Over the top, we have some inspiratory reserve volume that is utilizing when we are doing exercises or anything, and when we need extra amount of oxygen, like when we are panicked or anything, any situation, we have inspiratory reserve volume. So that is an active unit of the lung. Similarly, expiratory reserve volume, yes, in some situations we have tachypnea, we are exhaling too much amount of oxygen. Whenever we are under stress, we do deep breathing, so that we can exhale extra amount of oxygen, carbon dioxide out of our body. So this is an active unit of the lungs. So active unit, which is essential for the life, which is vital for the breathing, is known as vital capacity. So whenever you hear the word or read the word vital capacity, now you have crystal clear understanding. This is the vital part of the lung or vital function of the lung. And what is the vital function of the lung? Which is actively participating in the gaseous exchange, including your inspiratory reserve volume, your tidal volume, and your expiratory reserve volume. And the last is the total lung capacity. That is very simple. It is our total lung, including your residual volume. So this is all about lung volumes and lung capacities, and about spirometry and how we can interpret that. So if anyone have any question regarding this topic, you may ask me. Otherwise, I will move on to the next slide. Okay. Good, Dr. Iram. Okay, let's move on to the next question. Dr. Fatima, what increases or decreases? Okay, it depends on the clinical scenario. Are you asking about the pregnancy? Okay, this tidal volume increases during pregnancy by 40 to 50%, more classically 40%. Tidal volume increases during pregnancy. Why it increases? Due to the effect of progesterone. There are two factors which are mainly involving in the respiratory adaptation during pregnancy. One factor is your progesterone, which is triggering your respiratory center in your brainstem. One factor is that, and the other factor is your fundus of the uterus, the growing fetus, that puts the pressure on the diaphragm, and that diaphragm then decreases the residual volume. So during pregnancy, the residual volume as well as functional residual capacity, they would decrease. tidal volume would increase. However, the vital capacity do not change during pregnancy. And the reason behind is that why vital capacity doesn't change during pregnancy is that, yes, we know tidal volume is increasing, but at the same time, residual volume and the functional residual capacity decreasing. So that's why ultimately the net outcome is that vital capacity do not change. Am I clear now? So this is your physiological adaptation of respiratory system during pregnancy. And yes, there are many high yield points. When we covered this topic in the physiology, we had to understand what are the gaseous changes or the gaseous adaptation going on during pregnancy. Please tell me what are the metabolic findings in terms of gases during pregnancy? Any idea? Okay, what happens to the carbon dioxide? Yes, more specifically, it is respiratory alkalosis with metabolic compensation. Yes, carbon dioxide decreases. Yes, that's correct. Why? Because tidal volume is increasing. Yes. So we have covered physiology of respiration as well, because this is a high yield topic. Yes, that's correct. Hyperventilation, increased tidal volume, low level of carbon dioxide. Meanwhile, progesterone is triggering brainstem. All of these leads to respiratory alkalosis. But what happens? The body tries to compensate, the kidneys try to compensate, and they try to remove bicarbonate ions. So we classically, more specifically term this as respiratory alkalosis with metabolic compensation. Okay, Dr. Fatma, I think I have covered alkalosis in the physiology lecture, and we are going to cover the acid-base balance in the coming session on data interpretation. So we have a detailed topic on that in the coming session. Okay, let's move on to the next question. I'm setting my timer. Okay, your time starts now. Okay, your time's up. Yes, D is the right answer. This is your sagittal suture. So let me explain about different sutures. D stands for H option, so H here. Option D holds the statement or the word age. They're asking about to identify age point, and age is here pointing towards sagittal suture. Are you clear, Dr. Nada? Okay. In the question, they're asking about which alphabet is labeling sagittal suture. So this is your this is the sagittal suture, right? And H is labeling sagittal suture. And where is the H in the options? In the option D. Now clear? Okay, good. Okay, so the fetal skull, major bones are two frontal bones, two parietal bones, and one occipital bone. There are three main sutures in the fetal skull. One is the coronal suture, sagittal suture, and the lambdoid suture. So where is our coronal suture? Here you can see how it is forming. There are many variants of such questions. Like in this question, they directly ask you about after labeling that particular point, but sometimes they ask you about, they name the suture. Like for example, they may label that sagittal suture is formed by the fusion of which of the following bones. So this is another variation of this topic. So it's a good idea if you know like what type of sutures are formed by the union of what types of bone. Yes. So coronal suture generally extends from ear to ear. Each frontal lobe plate meets with the parietal bone plate at the coronal suture. So here's our coronal suture, and it is formed by the frontal bone and the parietal bone. Then sagittal suture in front of the head to the back, down the middle of the top of the head, two parietal bone meets at the sagittal suture. So if someone asks you the definition of like, or which of union of which of the following bones leads to the formation of sagittal suture, that means two parietal bones. Then lambdoid suture, this extends across the back of the head. Each parietal bone plate meets the occipital bone plate at the lambdoid suture. Here is your lambdoid suture, and it is forming by the union of occipital bone and the parietal bone. So this is all about the fetal skull and the sutures. Okay, let me set the timer. Your time starts now. Okay, your time's up. Yes, E is the right answer. And Dr. Gassan, why did you go with the option C?
I think this kind of ovarian lesions associated with the.
Okay, so do you know what this question actually means and from which topic this question comes from? Do you have any idea about the background?
Sorry, can I ask you? You hear me?
Yes, sure. I can explain.
Yeah, I choose ovarian because there is some ovarian lesions associated with increase of insulin and insulin resistance, which lead to manifestation in the form of canthiosis nigricans. This is my view.
Okay, okay, I will clear. Okay, for now, E is the right answer. The diagnosis, the spot diagnosis for this picture is acanthosis nigricans. It typically affects the neck and the axilla. And there are several non-malignant causes of acanthosis nigricans, such as familial, medication, and endocrine causes. You might see acanthosis nigricans in the patients who are having Cushing disease, so or Cushing in the Cushing disease or Addison disease. So if acanthosis nigricans is caused by malignancy, then GI cancers, most commonly stomach cancer, accounts for around 90% of the malignant cases. So looking at rest of the options, The E option, which is stomach, is the most associated with the acanthosis nigricans. As you can see here, 90% of the patients who have stomach cancer may develop acanthosis nigricans. So let me tell you the background of this topic. Basically, this question comes from the paraneoplastic syndromes. So what are paraneoplastic syndromes? These are the group of rare disorders that occur when the immune system has a reaction to a cancerous tumor known as neoplasm. In general, in a simple way, if a patient who is unfortunately have any type of cancer, sometimes their immune system react to that neoplastic tissue, and when that immune system after the reaction with the neoplastic tissue or the cells may develop some types of symptoms or complications or clinical findings, and we term such conditions as paraneoplastic syndrome. That means another group of syndromes or symptoms are going on along with the neoplasia or the cancer symptoms. So here are some of the important and the high yield paraneoplastic syndromes and their associated cancers. Try to remember them. If a patient who have small lung cancer, small cell carcinoma of the lung, or pancreatic cancer, they might develop Cushing disease, Cushing syndrome. They might develop Cushing syndrome. In the exam, you may find a question, a clinical picture in which that is pointing towards Cushing syndrome. And now in the options, they ask you what of the relevant cancer is associated with this condition. So this is how you will get the questions from this topic. So if you find a clinical picture of Cushing syndrome, and they're asking you about the cancer, the associated cancer, then go and pick the small cell carcinoma of the lung, because this is associated with Cushing syndrome. Similarly, in this question, they give you a picture of acanthosis nigricans and ask you the associated cancer. So the 90% answer is stomach cancer. Similarly, okay, Ghassan?
It's clear, I think, small lung carcinoma is called Cushing syndrome, Cushing-like symptoms, because there is a source of secretion like
Yes.
adrenocorticotropic hormones, which lead to elevation in the level of cortisol. But in stomach cancer, what is the mechanism which lead to acanthosis nigricans? It's associated with insulin resistance or increase in insulin level or causing hyperinsulinemia or something like this, or maybe cause hyperandrogenism. So what is the mechanism? What is associated manifestation or what associated pathology in stomach cancer leading to acanthosis nigricans?
Okay, at this very moment, I don't know the exactly mechanism, like what type of changes in stomach cancer happens which lead to acanthosis nigricans. I will find the answer and I will let you know in the WhatsApp group. Is that fine with you? However,
yes,
there are some other, okay. However, there are some other associations with the stomach cancer. In the exam, you may find some key points there. Maybe the patient may have a nodule on their neck, which is classical for the stomach cancer. There might be some changes due to the development of portal hypertension, because the portal circulation is so interconnected. If the liver is affected, the stomach, our upper GI, our esophageal circulatory system, rectal system, we might have varicosities. Similarly, if the stomach is affected, it may lead to some changes in the liver as well. Maybe the reason behind is that the stomach cancer may lead to the changes in the liver. There might be changes in the estrogen production that may lead to the hyperpigmentation. So there could be that mechanism. However, I will study that again and I will let you know the exact answer. So this is something which comes into my mind. It is related to something liver, which leads to estrogen changes, and that leads to hyperpigmentation, especially in the neck region and in the axilla. This is one supportive theory. Okay, so let's talk about the SIADH. If you find a clinical picture, the lab findings, in which you find hyponatremia. So hyponatremia is classical. Whenever you see hyponatremia, think about SIADH. So if you find hyponatremia in a patient and they ask you what is, yes, they may give you the finding, the diagnosis of SIADH and ask you about the associated cancer, then go again with the small cell carcinoma of the lung, or might be it is associated with brain tumors. Then similarly, dermatomyositis. If we see dermatomyositis that is linked to ovarian cancer, lung cancer, pancreatic cancer, GI cancer, non-Hodgkin's lymphoma. So all of these conditions may be associated with dermatomyositis, which is the inflammation of the dermis of the skin as well as with the muscles. Then we have polycythemia. Polycythemia is classically seen with the renal cell carcinoma and hepatocellular carcinoma. Okay. Let me set my timer for the next question. Okay, your time starts now. Okay, your time's up. A is the right answer, which is benign cystic teratoma. So anyone, yes, maximum I got the right answers. Okay, Dr. Fatma have mentioned she noticed a keyword mixed echos. That's why she go with the option A, which is right. Okay, sorry. Anyone who know what does mixed echos means? Why we find mixed echos in the case of cystic teratoma on the ultrasound? Yes, yes. Well done, Dr. Ruby, Dr. Larib. Yes. You all have good understanding of the basics. I don't know why you all are worried about the exam. You all are doing very great, and your performance is very, very satisfactory. Okay, that's good. All of you know that. And now I save my energy. There is no need to explain that further. Yes, Dr. Iram, you are doing great. Well done. Okay, I always forgot to set my timer. Okay, your time starts now for the next question. Okay, your time's up. Trichomonas vaginalis is the right answer. Okay, so how did you diagnose that? Don't worry, Dr. Ruby, you are just maybe panicked about the timer. Yes, it is protozoa. Yes, due to flagella. If you find flagella anteriorly, therefore flagella on the Trichomonas vaginalis, if you find that, go with the Trichomonas vaginalis. Yes, yes, green protein discharge. Okay, please tell me the treatment of Trichomonas vaginalis. How would you manage that? Oral or IV? Yes, perfect. Okay. And how will you differentiate Trichomonas vaginalis from bacterial vaginosis? Dr. Fatma, if you have that slide, please do share me on the WhatsApp. Okay. Yes, all of you know microbiology more than me. Okay, so what is the treatment of bacterial vaginosis? How you gonna manage the patient? Okay, how will you differentiate bacterial vaginosis, Trichomonas vaginalis from the candidiasis? Okay, what would be the pH status in case of candidiasis? Okay, that's good. And what is the treatment of candidiasis? Dr. Ruby, pH would be normal in case of candidiasis. Yes, perfect. Yes, clotrimazole local if pregnancy. Yes, that's perfect. Okay, so we have covered a bit about microbiology. Let's move on to the next question. Your time starts now. Okay, your time's up. I think most of you didn't check the ECG and all of you directly look at the thiazide diuretic and go with the hypokalemia. However, that's correct. D is the right answer. Okay, Dr. Larif, that's good. So tell me the ECG findings of ECG features of hypokalemia. Please tell me and tell everyone what are the features of hypokalemia on ECG. Yes, flattening of T wave. Yes. Yes, and U wave. Okay. So the features of hypokalemia, yes, flattening of T wave, and in some cases there could be inversion of T wave, followed by QT interval prolongation, visible U wave, and mild ST depression in severe hypokalemia. However, in a nutshell, the main point you need to remember is the yes, flattening of the T wave, and there could be visible U waves. So here I have, here in this ECG, this is an ECG of hypokalemia. There is a bit of inversion of T waves with the flattening of T waves, and there is a visible U wave. And if we look at this ECG, let me zoom in. Okay. So if we look at here, in the lead V3, we can see this classical finding. There is a flattening and inversion of T wave along with the prominent U wave. So this is an ECG of hypokalemia. You can appreciate the flattening of T wave here in this ECG. Okay, so let me go with the slideshow. Okay, so this is all about hypokalemia. So main ECGs you need to remember, those you cannot afford to miss regarding ECG interpretation is the hyperkalemia, hypokalemia, hypercalcemia, hypocalcemia, a bit from the atrial flutter, and also I think there was another syndrome, Wolff-Parkinsonian syndrome. I don't remember exactly what's name. I think it is Wolff-Parkinsonian syndrome. So these are the 5 to 6 ECGs you need to remember, and you need to know how to interpret that. Yes, Wolff-Parkinsonian, and the third, Wolff-Pickman. Okay, it's Wolff-Pickman. Okay, so this is an ECG you need to remember. Hypokalemia, hyperkalemia, hypocalcemia, hypercalcemia, atrial flutter, and this was something. So this is from your data interpretation. Okay, so we are moving on to our next question. Let me set my timer. Okay, your time starts now. Okay, I think I have got maximum answers. Your time's up. Okay, Dr. Ruby, your question was, will it be seen in hypokalemia, Osborne wave in hypokalemia? I think Osborne waves are mostly seen in hypothermia rather than hypokalemia. Okay, so let me show you. Yes, E is the right answer, beta HCG. So why I have added this question, I want to make sure you know how to interpret X-rays, chest X-rays. So whenever you see a chest X-ray, this is your from biophysics or maybe data interpretation. Ideally, whenever we have an X-ray, we start from the trachea. Always look, is the trachea central or it is tilted towards right or left. Then look at the clavicles, are they equal? Then look at the ribs, are there any fractures? Go and check the cardiac shadow. Look at the costophrenic angles. Then look at each of the lobes of the lung. Are there any findings, like any homogeneous findings, any infiltrates or anything? So this is how we generally look at any chest X-ray. For now, in this question, the question was very straightforward. They have already give you the diagnosis. They have already mentioned that the patient have had a surgery, an evacuation, and the histopathology shows the partial hydrated form mole. And we know that the ultimate complication, which is life-threatening and very dangerous, is a choriocarcinoma. And in this chest X-ray, they are showing the metastasis. Yes, cannonball appearance that is mostly classically seen in the lung metastasis. So in this patient, the patient may have developed choriocarcinoma or gestational trophoblastic disease that metastasize towards the lungs, and that's why we are seeing this cotton ball appearance. So yes, we know that the serum marker for the gestational trophoblastic disease is beta HCG. So E is the right answer. So this is all about your mock exam, and I try to edit all the spot diagnosis in this mock exam. So at least you are prepared regarding these questions, and anytime if you find such pictures in your exam, it would save a lot of your time, and you already have a crystal clear understanding how to tackle those SPS and how to answer that. So if anyone have any other question, you may ask me, otherwise I will move on to the next slide. We are done with the SPS. Okay. So what are the mentor's recommendation in terms of your exam preparation is that practice year-wise exam types question. You may watch exam-oriented lectures to wind up your preparation. Solve as many SPS as you can. Then must take mentor's advice while solving questions. You must solve mock exam before entering to the real exam. So mock exam is very, very important. It would not only help to assess yourself, it would also boost your confidence. It would help you to control your reflexes, your nerves, and it would also help to better prepare for the exam. So mock exam is very important. Dr. Nada, we have a lecture on CTG, I think a day after tomorrow. On 5th of June, we are doing a lecture on data interpretation in which we are including acid-base balance and how to interpret ABGs, CTG, how we can manage a patient according to the guidelines, and on the basis of CTG findings. So we have that lecture scheduled a day after tomorrow. Okay, so these are some of the recommendations. Yes, urodynamics, yes, that's also included. Okay, Dr. Kiran, when we will give COCP to choreo and molar after treatment, I'm not sure about the answer. However, I think it takes around 6 months. But I will confirm that. If any of the students knows the answer, please tell me. The question is when to give COCP to choreo and molar after treatment. Yes, definitely we will monitor the ECG levels. That's for sure. Okay, so 1 year. Okay. Okay. Yes, conception makes sense. There, we usually advise after chemotherapy to avoid conception for 1 year, and without chemotherapy, we go with the 6 months. Yes, Dr. Lerib, that's absolutely correct. No conception in 1 year if the patient had chemotherapy, and without chemotherapy, the answer is 6 months. Okay, Dr. Myra, did you see the both options together, like decreasing HCG levels and the normal HCG levels? Are those two options were together under the same question? Okay, please share me that question so that I can understand that question's context better. However, for conception, they have the set guidelines, 12 months with the chemotherapy and 6 months without chemotherapy. Okay. So if you want to practice more SPAs, we are arranging a workshop in which we are going to practice 24 SPAs, and we are starting that workshop from 13th of June. So if you want to participate, you are more than welcome. And okay, I have another question, Dr. Fatima. Okay, Dr. Fatima, basically the questions which are available on the website and the questions which are available on different books or the different material which is available in the market, more or less they have the same content. There is no such difference because all of them are focusing on the high yield topics. For instance, if you take a topic from the anatomy, like interior abdominal wall, so the what else you can extract from that? Okay, maximum, maybe the maximum SPAs from the interior abdominal wall would be 10 or 12 maybe. So that's the maximum amount of questions. So every book or every material do have the same questions. Okay, so coming back to my slide. Okay, if you want to participate, you are more than welcome. It we are going to discuss the SPAs mainly from the pool of 2019 to 2024 recall practice, and the mentors were available to answer all of your queries, and we will set the time. It would help you to boost your confidence, and it will keep you motivated that you have to appear in the daily SPA practice. And if you have any query, you can contact on this contact information on this number, or you may email us on this email address for your further queries. Okay, so if anyone have any question, you may ask me. I hope this session would be helpful for you. Yeah, thank you, Dr. Bhavna. I miss my premium students because it's been a while. I'm not in so much in touch with you. Dr. Myra, I miss you too. Actually, I have so many things. I have so many things in my plate. I cannot focus everywhere. But I try my best to be in touch with everyone. I try my best. Okay, thank you, Dr. Maya. Okay, so so I think we have no more questions. If you still have any queries, you are more than welcome to ask us. You may contact us over number, WhatsApp number, or you can email us as well. And if you still have any question, you can simply post in the WhatsApp group. We will answer that at our earliest convenience. So have a good day. Goodbye. See you next time.